I hope you all enjoyed our refreshing tea break and is now ready to continue our enlightening journey ahead. So, moving on, our next session is Symposium on GERD and Allied Syndromes. For this, I would like to call on the stage the moderators of the session, Dr. Surakshit TK and Dr. Prashant Buch, and as chairpersons, Dr. A. Sridevi, Dr. Ravi Daswani, Dr. Gaurav Chawla, and Dr. Sanjeev Sachdeva. Kindly come up on the stage and call upon the respective speakers of the talk.
Good morning, ladies and gentlemen. It's a pleasure to be here in Delhi. So my topic today is on gastric and supragastric belching. This is something which we all face quite regularly, not personally, at least in the beginning, but once we start seeing the patients, we also start having these episodes. So what do we mean by belch? Basically, it's an audible escape of air from the esophagus or the stomach into the pharynx. What is a gastric belch? Basically, the air is traversing both the lower esophageal sphincter and the upper esophageal sphincter. A supragastric belch traverses only the upper esophageal sphincter. And the prevalence of this condition with GERD is anywhere between a quarter to 75% of patients, and it is a little bit lower without GERD. So many people have this problem of belch. We all see patients who come to the OPD where particularly the spouse has to touch a certain point of the body to elicit a belch. If you touch, it does not happen. So I always tell people there are 3 OPDs in the hospital which there's something wrong in them if they are quiet. One is the ENT OPD where people keep doing then you have the pulmonology OPD where people are making different types of coughs, and then the gastro OPD where you have a different type of sound. So this is a typical OPD. People are sitting. It looks odd. Now you start getting the sound. This is on a good day. On a bad day, I'm sure you can all associate with this. So what is the mechanism of this belch? So I feel like I'm in the zoo. And I tell my secretary, please ask him to relax. If he keeps doing this, it will take longer for me because I'm not able to concentrate on this person sitting in the room who is not making these noises. And then it usually has the desired effect. So what is the mechanism of belch? So what you see here is, so air is swallowed through the upper esophageal sphincter. This distends the fundus, which sends signals to the brain. Once the signals are sent to the brain, the signal comes back, stimulating the transient lower esophageal sphincter relaxation, TLESRs, and this triggers secondary peristalsis with these air bubbles going back into the esophagus. As these secondary peristalsis keep going up and down, the patient feels some discomfort in the throat, relaxing the upper esophageal sphincter relaxation, triggering the burp. So this is simple mechanism of belch. Now we have gastric belch, which is of 3 types. One is the true belch, where swallowed air and gas that is produced by digestion in the stomach is expelled back up. This is not usually large volume. Then you have aerophagia, where the patient keeps swallowing the air and he is partially expelling it, but the rest of it travels down, causing bloating. So a patient comes complaining of belch and bloat, it is most likely aerophagia. And the third type is a special type, where the patient not only brings up the air, but predominantly by voluntary abdominal muscle contraction is pushing up the gastric contents, and as a byproduct bringing up the air also. This is a special type of gastric belch. Now, what about the supragastric belch? The type of noises that you heard in that OPD is probably this. Here the belch is arising only from the esophagus. What is the mechanism? There are 2 ways. One is pistoning in and suction. So pistoning in of the air into the upper sphincter by retracting the tongue base against the pharynx, and also a negative esophageal pressure which sucks in the air. Then the air expulsion is done by straining the abdominal muscles. There are no TLESRs involved per se, so there is no LES opening in these patients. So it is understood that a supragastric belch is a predominantly learned behavior. So what are the factors influencing this learned behavior? So what are the things that potentiate stress, maladaptive coping, anxiety, depression? All these things stimulate and maintain the supragas. So much so it becomes a conditioned reflex. I have this symptom, I have this problem which is not related to my gut, I associate with this and I start doing it. And some factors that reduce this are sleep and distraction. So in the history, if the patient tells, I don't get this when I'm asleep or when I'm busy doing something else, it tells you that it is most likely a supragastric belch. And very importantly, in gastroesophageal reflux disease, where patients may have ineffective esophageal motility, the unpleasant sensation of reflux triggers this phenomenon whereby the patient closes the ileus to prevent food coming out, but feels if I expel the air, I will feel better. So now I have a patient who is a 28-year-old actor. For 1 year, he's been having belch and a low retrosternal pain. His endoscopy was normal. His manometry showed ineffective esophageal motility. So hopefully this will play.
Starting video.
Can you see there? He's bringing air up. In the last portion, you'll see actually his tongue is moving forward and backward. So he's grating it in. And now as we get towards the last part, he's doing more repetitive movement. So now the same patient, having seen an HREM which showed only ineffective motility, I made him do the belch with the catheter in. Now just to understand what it is, here is another belch where person is retching. So you see that the stomach and the esophagus have become a single tube, but then at the upper sphincter there is no relaxation. So this is a retch rather than a belch. Whereas look at this. Looks very bizarre. I'll take you through this. Very interesting. Here, in the first portion, you see the person has done multiple rapid swallows and he is developing a almost looks like achalasia because the lower end has not relaxed. Next, what he is doing is, you see a inverse pan pressurization, that is from the stomach. So he is giving pressure and then he is relaxing. So that comes up as a belch. And now you actually see here, there are 2 more cycles of similar activity with reducing intensity. So this is how the esophageal manometry, the standard one that we don't use impedance manometry. So the standard manometry looks like this. You make the patient do the belch. You can distinguish between a gastric belch and a supragastric belch. So what is the relationship between GERD and supragastric belch? The relationship is bidirectional. As I already told you, as in the patient that we just saw, ineffective esophageal motility is found in almost half the patients with supragastric belch. 40% of SGB have a pathological acid exposure, and a third of the refluxes are actually induced by the supragastric. So what implication does this have to management? So if an acid reflux precedes the belch is secondary. So it is GERD, a PPI is helpful. Whereas when a reflex follows a belch, it is likely that a TLESR has triggered this, and baclofen may help in this situation. So how do we distinguish between a gastric belch and a supragastric belch? By history. So gastric belch tends to be postprandial, whereas supragastric belch can be any time except while asleep. There is bloat in gastric belch, especially when there is aerophagia, and there is no belch usually with supragastric. Gastric belch is associated with a few burps, but there are multiple per episode in supragastric belch. Gastric belch tends to be forceful, whereas supragastric belch may start forcefully but becomes more shallow as they have to keep taking the air in and bringing it out. Finally, you are more likely to see liquid and solid reflux, especially immediately after a meal with gastric belch, whereas mostly it is air with a supragastric belch. We have to distinguish as far as possible by a detailed history. Exclude underlying causes, very important to make sure you're not missing pancreatitis, angina, in addition to gallstone disease, peptic ulcer disease, in addition to gastroesophageal reflux disease. Upper GI endoscopy needs to be done, but it is seldom abnormal. Most of the time it is normal, but if you see evidence of reflux, then it is helpful that it may be coming from the stomach. So evaluation of belch, although I showed you the manometry pictures, 24-hour pH impedance is the gold standard, as it is useful to distinguish the belch type. So here you have a picture. The impedance rise is one way from the stomach. The channel closest to the stomach, you actually see from stomach upwards, the air is moving there is a depression dip here. As you go along, the plateau goes higher towards the right side. Whereas you compare it with the supragastric belch, the rise is actually two-way, so much so you get like a plateau here. See, first the patient has sucked in the air, so you see a rise in pressure, and then the patient is bringing it up, so the rise is steady, it doesn't drop. Also, impedance helps to identify any associated liquid reflux. That is, there may be acid or non-acid, as evidenced by drop in the pH after the belch in the impedance line and in the pH. So how do we manage belch? If it is a true belch, lifestyle modifications with PPI, prokinetics, sometimes digestive enzymes also. Lifestyle modifications will be dividing and eating, not leaving long gaps, not having a gap of at least 1.5 to 2 hours between food and lying down. Aerophagia, you teach them all these lifestyle measures, but also some breathing exercise, how to control the diaphragm, slow deep breaths, all those things. Rumination is a special type of gastric belch where it's very important to teach them cognitive behavior therapy. I'll tell you what it is soon, with or without using baclofen. And in SGB, if reflux precedes the supragastric belch, that means it is gastroesophageal reflux disease with secondary supragastric belch. You treat them with PPI, it helps. But if the reflux follows the supragastric belch, then you use baclofen to stop the TLESRs. And cognitive behavior therapy is again very important in managing these patients. What is cognitive behavior therapy? Cognition is the first part. What is cognition? You explain the problem to the patient in simple terms. You reassure them it is subconscious. It is very important to make sure they don't feel blamed for what is happening, because they don't realize they're doing it. They think they have a disease, they have a problem. So if you talk to them like it's all your fault, then they start feeling very bad about it. They think this doctor does not know what he's talking about. Surely I have a problem, I'm not doing it on purpose. So very important. And identify any prodrome feeling. Before it starts, they start feeling some tightness in the throat or in the chest. So they have to identify the problem and start doing the exercises to abort the event. So that is how you teach them. Now coming to the behavior therapy part, they need to be taught diaphragmatic breathing. Keep the mouth open and elevate the tongue. You saw that, the pistoning effect, how they are able to keep the pharynx and the tongue in a different position to bring the air in. To abort that, open mouth, tongue elevation. Train at least twice a day for 3 to 4 minutes. It may be in sitting or lying posture, doesn't matter. They have to keep doing that regularly. And if they practice effectively, then it is quite good for even up to 12 months. Hopefully by that time, whatever was triggering it, maybe some psychological issues would have changed, and they forget this learned behavior and they all become normal. It is very, very important that rather than us trying to teach the patients how to handle this problem, involve a speech therapist or a dedicated physiotherapist who is interested in doing these things. Because working with a speech therapist and a dedicated physiotherapist really works and makes a big difference to these patients. So there are certain scenarios where a patient has PPI refractory GERD but also has a supragastric belch. When the patient has severe esophagitis or non-erosive reflux and PPI is not working, can consider anti-reflux surgery followed by cognitive behavior therapy. Because once you do anti-reflux surgery and tighten it, the supragastric belch will increase. So you have to follow it up with cognitive behavior therapy. Reflux hypersensitivity, one needs to use pain modulators like gabapentin with cognitive behavior therapy. Functional heartburn, again pain modulator and cognitive behavior therapy. But I must add that further studies are required to provide better evidence for these and whether any of them can be used on their own rather than doing them in combined manner. So this is just a simple diagram of the initial treatment. Excessive gastric belch, acid suppression, lifestyle modification, fundoplication. When there is excessive SGB or rumination, CBD with diaphragmatic breathing, and then other psychological treatments. In rare situation, fundoplication. What can be used are baclofen medications, tricyclic antidepressants, and any other underlying pathologies which may be triggering need to be addressed. So, ladies and gentlemen, belch is a common condition and sometimes a problem. We need to classify it as supragastric and gastric based on the history, manometry, and pH impedance. Gastric belch needs to be managed with PPI, lifestyle modifications, and fundoplication. Rumination can be managed with cognitive behavior therapy, proton pump inhibitor, fundoplication, and supragastric belch to be managed with cognitive behavior therapy, baclofen or PPI, and pain modulator in the appropriate settings. So the problem with pH impedance as it stands is the system is not able to provide us automatic analysis of these belch episodes. So we are having to physically go and check them out. So I think in future, if the program is made a little different, it will help all of us to do a better job. After all, pH impedance is the gold standard for diagnosing supragastric belch and distinguishing from gastric belch. Thank you.
The questions will be at the end. The next speaker is Dr. Philip Abraham. He'll be talking on the management of eosinophilic esophagitis. Dr. Abraham needs no introduction.
Thank you, Prashant, for that no introduction bit. My gratitude to the organizers for giving me this chance to come here. I have only one disclaimer to make, that I don't have any of those Jurassic Park sounds that Srinivas had exposed us to. Instead, I'm going to speak on a condition that we see less frequently in India, much more frequently in the West, but we talk so much about it because we're so Western-oriented, and that is eosinophilic esophagitis. First, an overview. Many of us have thought of eosinophilic esophagitis as a component of GERD, and that's one myth that we should take away. It is an inflammatory condition, no doubt, infiltration with eosinophils, and isolated to the esophagus. We know that there are many conditions where there are eosinophils infiltrating the rest of the gut, and we know there are many other conditions where there's eosinophils infiltrating the esophagus, but here it is a constellation of symptoms that suggest EOE along with eosinophilic infiltration isolated to the esophagus. This part of the definition is very important for us. Both the components, the symptoms must fit in, and number two, the eosinophils must be restricted to the esophagus. So obviously, initially, we'll have to exclude all the other conditions where there's eosinophils in the esophagus. When we look at the epidemiology, unfortunately, from India and for much of Asia, we don't have data to talk about the prevalence or the incidence of this condition. So we have to fall back on what's happening in the West, which unfortunately is misleading for us, because this is a condition that's found more commonly in the Caucasian races. I'm using the term Caucasian not just to refer to that region, but all of Western civilization, where the prevalence is much higher than what we see, at least in our clinical practice. Maybe our focus is wrong. Maybe we're looking at the wrong subset of people to look for EOE. But in the prevalence, you notice that when you look at the the Caucasians, even among them, there is a difference in distribution. So you have some studies saying that it's more common in North America as compared to Europe, more in males than in females, more in adults than in children. Incidence also corresponding. But we have an equal number of articles that say that no, all across the Western world, this condition has the same prevalence and incidence. What we do know is that in the West, at least, this condition is progressively rising. Incidence is increasing with time, and in many countries, it is easily the most common cause of dysphagia, something that most Indian clinicians will not accept. What are the diagnostic tools that we use to diagnose this? There have been more than 40 inflammatory biomarkers that have been evaluated to make a diagnosis of EOE, and none of them has stood the test of time. So we do not have a reliable biomarker for the diagnosis. So we fall back on endoscopy. Unfortunately, endoscopy is also not a reliable tool, and we have to fall back finally on histology. It's important for us to focus on whom we should do a biopsy on, rather than taking a group of patients who present with GERD symptoms and then do biopsies on all of them and say that this condition doesn't prevail in India. We need to have typical symptoms, and it's important for us to identify what are those typical symptoms. Even in the West, where the condition is common as compared to India, the average time to diagnosis is about 3 years. That means these patients go through many other forms of treatment before they come to the right diagnosis. When to suspect is very important. And I know that, me included, many of us clinicians focus on the group who come with GERD symptoms. What's important, very important, as these patients present with esophageal motility problems. right from childhood all the way to adulthood. In adulthood, in fact, they present with only dysphagia and food impaction. In children, we'll have feeding difficulties, that is, in toddlers and young children, vomiting and regurgitation, failure to thrive, abdominal pain, coughing while eating. As they grow older, they'll have some heartburn, no doubt. They may even have regurgitation, but dysphagia starts coming up in children. And in adults, it's almost always purely dysphagia and food impaction. That is a group that we should look at where we do not identify any other etiology. That's equally important. So naturally, the diagnostic approach means first, look at the right cohort of individuals where you should be suspecting EOE and then do an endoscopy, take biopsies from at least 2 regions, 4 to 5 biopsies from each location, preferably of PPI, and we'll come to why that is so. And once you find that there are active eosinophils, that is defined as more than 15 per high power field, that's when we look at, is this eosinophils restricted to the esophagus, or do we have a distribution happening elsewhere? Is there any other cause for the eosinophils? And only in the absence of any other cause do we make a diagnosis of EOE. And there's a host of conditions in which you can get that. So endoscopic pictures, of course, vary from time, vary with the age of the individual. You may have a normal looking esophagus. On the other hand, in children, you may have edema, followed by rings, and then the exudates, furrows, and finally what we see in adults as strictures. So if we know this spectrum and which age to look at for what abnormality, we'd probably be picking up more of EOE. And I suspect we won't have the prevalence that we have in the West, probably falling back on the hygiene hypothesis. Histology, it's all about eosinophils. Not only do we have a lot of eosinophils, but we have also a basal zone that occupies more than 15% of the total epithelial thickness. We have eosinophilic granules, eosinophilic aggregates, eosinophilic abscesses, all the way with eosinophils, finally leading to more fibrils and more fibrosis as an end result of this. So it's not just the question of identifying eosinophils, but looking for eosinophils all over the place, along with or without fibrosis. Differential diagnosis, huge. So I put in red the conditions that we see in clinical practice so frequently. We know about the hypereosinophilic conditions. We also know about eosinophils involving the entire GI tract. But some simple conditions like GERD may also have eosinophils in the esophagus, esophagitis, achalasia for that matter, Crohn's disease conditions where we don't see involvement of the esophagus so frequently. But that's another condition where we have it. The ones at the bottom are the ones that we see less frequently. But there's a host of conditions that you need to rule out before you make a diagnosis of esophageal or eosinophilic esophagitis. As of today, we don't have a permanent cure for this condition. If it's a type 2 allergy, which means interleukin involved or interleukin related inflammation, we don't have a drug that will talk about permanent cure. So our aim of treatment is 1, improvement in the clinical symptoms, preferably associated with endoscopic improvement, resolution of the eosinophils and other histological abnormalities, improved esophageal function, because that's what the patient came to us with. He came to us with dysmotility, he came to us with dysphagia, so improved quality of life, no long-term adverse events of the treatment that we give, and prevention of disease progression and subsequent complications. Like I said, no permanent cure, unfortunately, for this condition. So the management approach, we mentioned right in the beginning that you don't have to have the patients off PPI before you make a diagnosis of EOE, because the first line of management usually involves a PPI. And you may get 60 to 80% symptom relief just with the administration of PPI. In Western countries, they also use topical swallowed topical steroids and elimination diets as first-line treatment before they go on to the second line. And we should remember that more than 70% will respond to the first-line treatment. Our further steps will depend on whether there is response to it or not. So we have the group that has no remission, and then we go further on and look for, is there any other diagnosis, or do we have to go higher on our treatment? Those who have histological remission but with persistent symptoms, then you look for endoscopic healing. You also may have to go up to dilatation. Those who have clinical and histological remission, then you look for what should we do for them for the long term. So the response to primary line of treatment, which is PPI, topical steroids, and diet modification, will tell us where we go further. What are these elimination diets? Things that we talk about when Dr. Ghoshal was talking this morning about FODMAPs also overlaps with what we call elimination diets. And what kind of elimination diet to follow or what plan to follow will also depend on which age group we are dealing with. When we deal with children and adolescents, we prefer to have what is called the step up elimination diet. Advantage is that you don't have to take up too many items. Milk and gluten, of course, are any nutritionist's favorite for eliminating in the first place. You eliminate 2 items, then you eliminate 4 items, then you eliminate 6 items. And you give enough time for each of these and do an endoscopy at each stage. So the advantage is that you're restricting it to only 3 endoscopies per session, per the entire course. Also, we are eliminating very few items, which makes it more pleasant for the children. But the disadvantage is it's less effective. It takes time. On the other hand, in adults, you eliminate 6 items and then reintroduce them one by one because adults are more tolerant, I believe, most of us are. The problem is you need to do an endoscopy after reintroducing each item. So you'll end up doing 6 or 7 endoscopies, which adults may not tolerate so well. So the disadvantage is that it takes time, high diet restrictions, so less compliance, and indications are, of course, in adults. The cost of treatment or the cost of this approach is also high. So we have the step up for the young ones, and we have a top down for the adults as elimination diets. I don't know how many of us in clinical practice ever needed to do this. Now, this one drug has come as a hope for those who are resistant to the first line of treatment, that is dupilumab. This was a drug that was first approved by the US FDA for other allergy conditions. 7 years ago, it was approved for use in severe atopic dermatitis and also with chronic rhinosinusitis with nasal polyposis in adults. It took another 5 years for the drug to be approved in the treatment of resistant EOE. We hardly ever make the diagnosis. When we do, we usually treat them with PPI. I don't think in the near future we will need access to this drug. But yes, there are other conditions where the drug may be useful. In 2022, it was approved for prurigo nodularis and later on for EOE. And quickly following on the footsteps of the US FDA, the American Academy of Allergy, Asthma and Immunology, the AGA, and then the EMA. The European Medicine Agency also has approved this drug. Dose is, of course, fixed, 300 milligrams, but it's restricted to use only in adults, that is, those weighing above 40 kilos, and in children above the age of 12 years. So we have hope for the future if ever EOE becomes a major problem in India. So if I have to summarize, ladies and gentlemen, the management of EOE depends on 3 Ds, what we call diet, drugs, and dilatation. This recommendation says you can use any of the first 3 lines of treatment, diet or drug, that is topical steroid, or pharmacotherapy, that is PPI, as the first line treatment. And based on the response, you go on to the next line of treatment. So if there are red flags, that means if the patient has dysphagia and a documented stricture, you would, of course, go for dilatation as the first line, in addition to the others. If you're taking the first line and not going along the red flag track, then the further decisions will depend on whether the patient has histological, endoscopic, or clinical improvement. Based on these, you'll manage your next line of treatment with dilatation as a final step for those with stricture. Thank you very much.
Was the lecture short because it's a rare disease in India? The final speaker for the session will be Dr. Arun, who is from Kakinada. He'll be talking on advances in GERD management.
Good afternoon, all. So, my topic is advances in GERD management. So, in my talk, I would be mostly focusing on the treatment aspect and not on the evaluation aspect. So, if you look at the therapies for GERD, they can be broadly classified as pharmacological, endoscopic, and surgical. So, what are the ultimate goals of therapy in GERD? So, these include resolution of symptoms, healing of esophagitis. Once symptoms resolve, so you need to maintain the symptom remission as well as the esophageal inflammation, and ultimately the quality of life should improve. So the pathophysiology of GERD is multifactorial. The most important include increased gastric acid refluxing into the esophagus. Others include abnormal esophageal clearance, acid pocket, dysfunctional LES, gastroparesis, and decreased esophageal mucosal resistance. But unfortunately, the most effective pharmacological therapies till date act only on the gastric acid, and most of the other pathophysiological aspects are often like not targeted, or we do not have much effective therapies to target the other factors. So, till date, PPIs provide the most effective healing of erosive esophagitis and symptom relief in GERD patients. And we have seen this over the past 30 years. PPIs are very good drugs. They score superior to H2 blockers. If you look at the symptomatology in patients who take daily PPI, almost half of them experience breakthrough symptoms or persistent symptoms while they are on treatment. And if you break them up, 90% of them experience either heartburn or a combination of heartburn and regurgitation. So these are all unmet needs of traditional or conventional PPIs. And if you look at the data in advanced erosive esophagitis, the failure rate of PPI can be almost up to 40%. So what are the limitations of conventional PPIs? They have a short half-life. So the duration of action is shorter. There is incomplete inhibition of gastric acid, and nocturnal acid breakthrough is really a problem. So we all know PPI should be strictly administered before meals. To counteract some of these limitations, some stereoisomers and extended release PPIs were developed. These include dexlansoprazole, extended release preparations of rabeprazole and pantoprazole. Most of these PPIs, traditional PPIs, are metabolized via the CYP2C19 pathway, and we all know that this enzyme is subjected to genetic polymorphism, which in turn causes variable metabolism of drug and reduced bioavailability of the drug. So to manage this limitation, some PPIs were developed. These include ilaprazole and tenetoprazole. Though Chinese studies showed good promising results about ilaprazole and tenetoprazole, it did not reflect really in the clinical practice as shown by some of the Indian studies. So there are some limitations for which we do not have any answers. So the onset of action of PPI is slow. So they take maximal action after 3 to 5 days, and most of them are entry coated because these drugs are unstable in gastric acid. So if you look at the healing rates of different PPIs, this was a recent meta-analysis that showed that most of the commonly used PPIs is esomeprazole, pantoprazole, lansoprazole, and so on. At standard doses, they have similar effectiveness and acceptability. And surprisingly, dexlansoprazole, which is expected to have a dual release mechanism, had also similar effectiveness compared to the older PPIs, but the discontinuity rate was higher with dexlansoprazole due to different reasons. So now we have these novel next generation acid suppressants. These are potassium competitive acid blockers, or in short we call PCABs. Vonoprazan has been the most extensively studied PCAB. So it was in clinical use in Japan since 2015, and we have got DCGI approval this year in May. So briefly, what PPIs and PCABs do at the parietal cell. So PPIs, they are converted into an active form in the acid milieu within the parietal cells, and they block the entire enzyme, that is potassium H plus K plus ATPase, irreversible in an irreversible fashion. But on the other hand, PCABs, they irreversibly bind only to the potassium binding site of the HK ATPase pump. And the concentration of the PCABs within the parietal cell is several folds higher than what we achieve with PPA. So if you look at the pharmacological differences between PPI and PCABs, PPIs are vulnerable to gastric acid. So they are usually enteric coated. PCABs are acid stable. So PPIs are prodrugs. They have to be activated into an active drug by the gastric acid. So it needs acid for activation, whereas PCABs are active drugs. So PPIs, as you all know, they block only the actively secreting parietal cells, whereas PCABs can block both the active and proton pump. So what is the clinical implication of this? PCABs do not have any relationship with meal. You can administer before or after the meal. So PCABs have a long half-life of almost 9 hours, and it is metabolized by a different mechanism other than CYP2C19, mostly by 3A4 mechanism. So onoprazan, the most extensively studied PCAB, has a rapid onset of action, and it produces profound gastric acid suppression on day 1 of administration compared to most of the other PPAs. So this was a multi-center study done across different centers in US and Europe. So this was a phase 3 non-inferior trial where they compared onoprazan with lansoprazole over an 8-week treatment, and they looked at the healing rates of erosive esophagitis. Onoprazan was non-inferior to lansoprazole, and especially if you look at a subset of patients with severe erosive esophagitis, onoprazan was better than lansoprazole in healing them. Again, a meta-analysis showed onoprazan compared to any other PPI in GERD showed similar healing rates of erosive esophagitis, and in fact, it fared well over other PPIs in healing of severe esophagitis. So this was a study from the Japanese group that looked at the role of onoprazan in maintenance treatment. So they took patients of GERD who were already on PPI maintenance. They administered alternate days onoprazan or lansoprazole, and after 1 month they crossed over to the other drug. So the symptom control was overall very good with vonoprazan. The rapidity of action and maintenance of the effect was superior with vonoprazan, and the adverse events were almost similar in both groups. So this was again a recent meta-analysis which compared the available 3 PCABs, Ono, Tigo, and keverprazan, and compared with other PPIs. They found that the healing rate was better with PCABs compared to PPIs. So since it has been extensively used and studied in Japan, so let us take some take-home messages from the Japanese guidelines. So onoprazan is considered as a first-line treatment in patients with severe reflux esophagitis. It is preferred first-line treatment in maintenance of mild and severe reflux esophagitis, and also it is the first-line treatment that is preferred by the Japanese for intermittent or on-demand treatment of patients who have NERD with a proven excessive acid exposure. So before embarking on more add-on therapies such as alginates, baclofen, prokinetics, and subjecting the patient to invasive treatments, so let us realize that GERD is a multifactorial disease. So you need to pathophysiologically phenotype the GERD and provide a personalized care to these patients. So most of the acid suppressants, pharmacological therapies work only if patient has an ongoing reflux, either acidic or non-acidic, and they are not going to work if patient has reflux hypersensitivity or functional heartburn. So having said that, so endoscopic treatment of GERD, it can be classified as radiofrequency ablation, the plication techniques, and the anti-reflux mucosal resection or reconstruction. Of these, strata and transoral incisionless fundoplication has been widely studied. You know, they're all FDA approved. And the area where new techniques are being developed is the anti-reflux mucosal reconstruction. And off late, to start with, we had arms, then ARMA, and off late we have something called as mucosal valvoplasty. So basically, we are reconstructing the mucosa around the cardia. So before subjecting these patients, always understand, choose the right patient for anti-reflux endoscopic or a surgical therapy. So these patients should be symptomatic, having typical GERD symptoms, with objective evidence of reflex pH monitoring, regurgitation predominant patients, and those with hiatus hernia. So these are the patients who would benefit from an anti-reflux surgery. If you look at some of the data of endoscopic full thickness plication techniques, this is a recent meta-analysis that included 13 RCTs and observational studies. So the PPI cessation rate and improvement in quality of life was almost 65% at the end of 1 year, and there was modest reduction in the esophageal acid exposure. So the safety profile was also reasonable, but remember, these are not head-to-head trials. They have all been compared with sham groups. And ultimately, you need to compare any endoscopic treatment with that of a surgical treatment. So if we look at some of the data comparing endoscopic versus the surgical treatment, there have been of late 2 meta-analyses that included only such kind of studies. So what they have reported, so TIF was no different from surgical fundoplication, and strata was inferior to TIF and surgical fundoplication. And also it's interesting to know that the PPI discontinuation rate or cessation rate was much higher with lab fundoplication compared to endoscopic plication. So summarizing, always remember pathophysiology of GERD is multifactorial, and I have told you that most effective pharmacological therapies target only one aspect of the pathophysiology of GERD, that is the gastric acid. So PPIs are the cornerstone of treatment, but they have some limitations. So now we have PCABs, so show promising results. They are non-inferior to PPIs with superior healing rates, especially in severe erosive esophagitis, and they appear to have a role in the future. But we need to follow these patients, and we need to see what kind of adverse effects or side effects they develop in the future. So always remember, the management of GERD should be personalized. So do a detailed pathophysiological testing, phenotype them, and then you decide on add-on therapies. Endoscopic anti-reflux therapies require careful selection of patients, and we all know that there are different types of endoscopic surgeries, and the anti-reflux mucosal reconstruction techniques are evolving due to time constraints. I have not shown you some of the videos, but yeah, this field is promising and it's evolving. So we need more data on it. So if you compare the head-on trials, endoscopic plication versus the surgical plication, the TIF for which we have the evidence is the greatest. There is no significant difference compared to surgical fundoplication, and PPI discontinuation rate is still far higher with surgery compared to some of the endoscopic plication techniques. Thank you.
Thank you, Dr. Anand. Thank you, Dr. Anand. Now we can have a few questions from the audience.
So my question is to Dr. Philip Abraham. Sir, we do encounter in our clinical practice quite few times patient having refractory eosinophilic esophagitis. Means we try double dose PPI, then food elimination, and they don't respond, and even they don't require the repeated dilatation, but having a persistent histological activity. As we don't have any standard preparation for topical steroids, so how to titrate the topical steroid? And as the dupilumab is not available in India, should we try some systemic steroids or immunosuppressions? What's your take on that?
So here I'd like to draw a parallel with what we call microscopic colitis, where we treat the patient for symptoms. And then if the patients do not respond is when we think of higher forms of treatment. Here we have eosinophils, but the symptoms are not directly related to eosinophils, but because of the dysmotility that they have. So if none of these forms of treatment work, then maybe you'll have to think of oral steroids, but that's not a recommendation. That's more like a measure of desperation because nothing else seems to work, and there is no endoscopic intervention that you can do.
And to Dr. Srinivas, like, sir, as you have suggested the cognitive behavioral therapy for the Belchis and rumination, like many people have tried the biofeedback also in this, like they're putting manometric catheter and doing a behavioral therapy. Like, what's your take on that? Yes.
I suppose that's a painful way of doing it. I think it just requires them to understand what is happening and start doing. See, even for your fecal evacuation disorders, the reason for putting the catheter and doing is just to show them what they are doing wrong. So I suppose, but there the problem, it is not that difficult for the patient because it's quite painless to keep the probe in the anal canal, whereas here it is much more difficult. So you could do that to show them. That could be only in selected patients who are having much difficulty in understanding what they're doing and how to make modifications.
I'm Dr. Prashant Bhandarkar from Nagpur. Question for Dr. Philip Abraham. A lot has been written about the risk of dilatation in eosinophilic esophagitis. So, what precautions you need to take, and is biopsy also carries some danger?
These are acceptable risks that we have to take. The same precautions that you would take for any fibrotic stricture, where you know that there is a risk of perforation if you exceed the pressures required, we'll have to do it the same way. But there is no recommendation as in achalasia or fibrotic strictures of other etiologies where we look for either the pressures or waist obliteration for adequate dilatation. But the principle would be the same as for any other stricture. As far as the risk of biopsy is concerned, it's not a significant risk. It's the same risk that you would use with any spike biopsy forceps in any esophageal condition. The presence of eosinophils does not add to the biopsy risk.
Dr. Philip, can I add, sir? Dr. Abraham, sorry, a quick question, just a small addition. The biopsies, like for example, for EOE, we used to have a criteria, like we used to do lower esophagus, upper and mid esophageal biopsies because GERD does influence the eosinophilic rate, and there can be a misdiagnosis or an underdiagnosis. So when you take it from 3 different sections of the esophagus, I think the diagnosis yield is much better. That's the protocol we used to follow at Northwestern.
Yeah, that's a point that needs to be re-emphasized. Am I audible? That's a point that needs to be re-emphasized, that you do not take biopsies from one segment. The recommendation is minimum 2 segments and 4 to 6 biopsies from each segment. So you begin with the bottom, but you don't restrict yourself to the bottom. 2 minimum, 1 above the other, and 3 preferable.
And also, I think one of the audience asked about the steroids question. Even in US, steroids are not approved by insurance companies, tropical steroids. So they use the asthma inhalers as the second line therapy after double dosing the PPIs. And one more question to Dr. Srinivas is like belching and also GERD. At what point would you start thinking of a pH on when your PPIs are not effective? I know you've mentioned that for anti-reflux surgeries, you are going to go through the strict criteria of monitoring your pH and doing a Bravo study and doing that. But is it at some point when your pH PPIs are not working that you would do a pH testing and maybe go for cognitive behavioral therapy like hypnotherapy or something, which goes same for Mr. Arun and also suprabelching syndrome for Mr. Srinivas?
A lot of times, it's like, again, so many chicken and eggs we have seen today. It's again like chicken and egg. Once they've been having a problem for a long time, it's difficult to distinguish. That's where the 24-hour impedance helps. If you see that the acid reflux is happening after the belch, it is likely a secondary reflux. If you see the acid reflux is happening before the belch, it is likely to be a gastroesophageal reflux. So in the situation of the latter, then you have higher, you have a lower threshold to consider surgery under the appropriate situations.
My question with Dr. Philip Abraham, sir. In a patient with eosinophilic esophagitis, see, we do have these topical steroids and this 6-foot elimination. That is the two things that we offer to the patient. It is very easy to go in. How do we decide how to step down? Is the first the 6-foot elimination goes out or the steroid goes out? When do we follow for the biopsies? Do we do the biopsies on the treatment? Do we take some particular time of, say, a cooling period of 4 weeks to repeat a biopsies, so that we say the patient has been cured of the disease has gone in remission, or is it going to come back? How to follow these patients?
The first point that we need to remember each time is that there is no permanent cure. So follow-up is for as long as the patient has symptoms. Now, how long to persist with each mode of therapy? It's a minimum of 2 weeks. An endoscopy is not done after a lag period, but while on treatment, because you're looking for endoscopic resolution as well as histological resolution. So it has to be done while on treatment, and the minimum duration is 2 weeks, preferably 4 weeks.
Dr. Arun, question to you. After we stop this treatment, after we have followed the patient has gone into remission, we have this histological remission and the clinical remission with 6-foot elimination and topical steroids. So do we need a protocol that we repeat a biopsy after stopping this treatment after 4-6 weeks, or it will be a guide on the basis of the symptoms?
It will be based on symptoms. All we need to remember is that these patients may keep following up for the long term. It will be based on symptoms, because the first aim is really to relieve the patient of the clinical symptoms, then the endoscopy, and then the histology. Histology is not, as of now, unlike in IBD where we talk about treat to target, here histology is not the target for discontinuing treatment. I mean, not the target for restarting treatment. The target is quality of life and symptoms.
And any role of systemic steroids if the patient does not respond?
Yeah, that's a question that someone else had asked. I think Prashant or somebody else had asked, and the question was brought up here as well. It's not a part of recommendations, it's not a part of guidelines, but we do that in a patient who does not respond to any other form of treatment, short of the biologics.
Excellent talk, Arun, about your GERD. My question is, there is a subset of patients, severe esophagitis, who don't do well with PPI. So they are kind of these PPI refractory. Now the surgeon is quite reluctant to operate. So what's your take on that? And then another small subset of patients who don't have a good motility, so that they do have impaired esophageal clearance. How do the interventional interventions do they have a role, or what's your take on this?
So the first thing is if the esophagitis is severe or if it is not healing, so I would always go for a pH testing on PPI, or once daily or twice daily. So we have a case of proven GERD by presence of severe esophagitis. And we need to do a pH, preferably with impedance, on acid suppression. So then we'll come to know what's the percentage time of gastric acid is being suppressed by the present drug. And we can also convince the surgeon. So if you send this patient directly to a surgeon, he might not be convinced. Otherwise, if he's an aggressive surgeon, then it's okay. But if he's not that kind of surgeon, so we need to support the case with an objective evidence. So you can always do a pH study, show the surgeon that this patient has 100 reflux episodes, this patient has 150 reflux episodes, and you all know that PPIs they only block the acid. So there'll be some going on, alkaline weakly acid or alkaline reflux going on. So that also might be causing these symptoms. So in that way we can convince the surgeon, number one. Number two, you know that how good the drug is working. So we now have these kind of more potent molecules like vonoprazan and other PCABs, the pipeline. So you can always switch to other drugs. So we are lucky enough to have those drugs. So we can always switch to other drugs, or increase the dose of PPI, switch to other drugs. After reviewing the literature, I won't suggest some of these newer PPIs like extended release preparation and all those things, because data doesn't suggest, these or support these molecules. So I would prefer switching the patient to a PCAB, and then uh, first try to heal the esophagitis, and then maybe in the course of time refer to surgeon. So the next question is if the patient has ineffective esophageal motility. So long-standing reflux, as the studies have suggested, long-standing reflux, severe reflux per se can cause ineffective motility. So we need to control the reflux. By controlling the reflux, sometimes the esophageal motility can come back. And also we can also do these kind of provocative testing on manometry like MRS and all those things to look at the esophageal peristaltic reserve. So if MRS is good, then fine. You can still convince the surgeon that peristaltic reserve is preserved. Or otherwise, I would always suggest optimize acid suppression, lifestyle modification, so on, add-on therapies, and we need to titrate the medical management, and then we need to find the right time when the patient should be subjected for surgery.
Dr. Arun, this side. If the patient has mild symptoms, very occasional, rare symptoms, and he has, say, once in a week or occasionally, would you recommend just all along we keep just giving an H2RA, ranitidine, that acts fast, and patient has a relief within 6 hours and he does well? What's your take on vonoprazan versus a simple drug like ranitidine?
Yeah. So if a patient is minimally symptomatic and doesn't have erosive esophagitis on endoscopy, then the target of our treatment would be only symptom control. So that can be on-demand treatment, because we know that there is no mucosal damage happening and the symptoms are only minimal. So in such a situation, the minimal drug, the basic drug with a minimum dose can be used as an add-on, as an on-demand therapy. There is no problem with this. But if you look at the Japanese guidelines that I had shown you, they clearly mention vonoprazan or the PCABs should be used in those patients with NERD, non-erosive reflux disease, who have ongoing acid reflux. So PCABs are preferred only in such situations. But if a patient is happy with a H2 blocker, once in a week or so, then you can continue such a treatment. There is no wrong in doing that.
One small question.
One question.
Yes.
Like you mentioned regarding prokinetics, which prokinetic to be used in patients with belching?
So we need to understand that prokinetics do not act on GERD directly. Prokinetics do not have any effect on the lower esophageal sphincter. Prokinetics improve GERD symptoms by only increasing the gastric emptying rate. So we need to understand this concept. So prokinetics as such do not have a direct role in GERD. So there are some subset of patients where prokinetics can be useful. Number one, those who have associated postprandial bloating, postprandial fullness with GERD symptoms, prokinetics will definitely act. Or if you feel that patient is having profound gastroparesis symptoms such as vomiting and all those things, yes, because gastric emptying study is not available everywhere. So it's a difficult investigation done only in the nuclear medicine department and all those things. Okay, so that we need to understand. And number two, the choice of prokinetic varies. So there are a lot of prokinetics in the market, but none of the prokinetic is safe. So if you start the patient on a prokinetic, kindly do not continue the prokinetic for more than say 2 or 3 months. It's not advisable, and I would not pick up a single prokinetic. We have all prokinetics have similar side effect profile, and if you ask me to pick up one prokinetic of this group, I would go for etopride, and maybe followed by as per your choice. But always remember the side effect profile of prokinetics.
Sir, I have a question for Dr. Philip Abraham. Sir, we take eosinophilic esophagitis as a prototype of eosinophilic mucosal disorder. Now, it presents with dysphagia, and we know that eosinophilic esophagitis can present with variety of findings on esophageal motility on HRM testing. So, where do you place the utility of doing an esophageal manometry in patients with eosinophilic esophagitis?
If I had such a patient, I would send them to Professor Bhatia. HRM is not part of the workup of eosinophilic esophagitis. You could do that for research purposes, but there is no diagnostic criterion to say that this is what will happen in EOE, because the changes that occur both histologically, endoscopically, and in motility is so variable.
Dr. Arun, one question, like PPIs, we take empty stomach. So now vonoprazone can we take any time for proven GERD patients? What do you recommend to the patient? What time to take vonoprazone?
So I don't have any personal experience. If you look at the evidence, vonoprazone can be taken at any time, before or after food.
So practically we can give empty stomach, or like how?
Yeah, we can give vonoprazone on empty stomach.
And second question is, do you think because it is helpful in peptic ulcer disease, H. pylori eradication also, will it replace the PPIs, no, PCABs? Because it has not been studied in Indian population with our diets and all. What do you think, what will be the future of PCABs?
So I still I will not commit that it's cutting down on PPI. Still, PPIs have their own role, because like it has been time tested. We've been using it for last 3 decades. But yes, I expect like a lot of studies, maybe a minimum of 100 studies that will come up from India next year, and we will come to know the exact data and the evidence to support vonoprazone in our Indian patients. So we need to wait and see, like, and also the side effect profile as well. So,
Thank you very much. I think we can call the session an end now. Thank you all the speakers.
Thank you all the moderators, chairpersons and speakers.